Thanks, Austin. It's really a pleasure to be here with you this evening. It's my first trip here to Stanford, so I appreciate the invitation and thanks for your attention. We'll go through some of this and should have some time for questions at the end. I hope that there are some, because I hope to be somewhat provocative. But first, before I get onto that, I want to start on a legislative note, not what you were expecting, but I wanted to just to show you this little snippet from an actual bill that was presented to the Iowa Senate a couple months ago from Senator Shelgren from Ottumwa. I'll blow up this little relevant part here. That it says the State Board of Regents of Iowa shall prohibit any collaboration between the institutions of higher learning in Iowa and Stanford University until Stanford officials publicly apologize for the unsporting behavior of the band during the Rose Bowl game. So I just wanted to let you know. That I am. I've been authorized specially by the governor to accept that apology. That departments of otolaryngology count as Stanford University officials, so I will be available after the talk.
Everybody stand up and turn your back to the speaker.
Anyway, I don't even know what happened in that game. So I'm going to talk about survivorship and why it's a topic in the first place. It's probably the place to start about it. And then we'll go on to talk about screening tests during survivorship and how I like to think about them. The issue of harms of screening is something that we should be thinking about as we design and implement screening tests. And then really try to answer the question about what should we really do with our patients, because this is a question that we answer on a day-to-day basis. So I have two quotes here that were written that came out of a monograph that was written by the Institute of Medicine in 2005. There are times when trends in medical science, health services research, and public health awareness converge to forge a new realization. So the world is changing, as described in 2005, and a legacy of physical, psychological, social, vocational, spiritual, and economic consequences with unspoken and hidden disabilities that follow successful treatment. Successful treatment. So there's no longer cancer that we're dealing with, but we've got an enormous load of things that maybe we ought to be helping patients with, or things that patients need help with afterwards. So that was from a monograph called Lost in Transition, which is sort of an interesting play on words, but I think it really speaks to this new realization that happened about 10 years ago, that survivorship is a thing, to use a modern turn of phrase, and something that we ought to pay attention to differently than we pay attention to change or questions about how we ought to manage patients that have cancer. So the Institute of Medicine described this need to focus attention on the experience and needs of survivors, because they are different specifically than the experience and needs of cancer patients. And especially in 2005, and even more so now, that the complexity of cancer treatment is only greater, that we probably haven't seen the true complexity of treatments, as we are now 20 years after some of the foundational studies that now have us using chemotherapy for patients. We are now seeing, only now, the true long-term toxicities of those treatments. And so they created 10 different recommendations for what we ought to do as a national cancer treatment enterprise related to survivorship. And the recommendation number 3 was that we ought to create evidence-based guidelines and interventions, because they don't currently exist, or they didn't at the time. So here's the very, very simple schematic about how this ought to look: that there ought to be a head and neck cancer survivor, that there ought to be a body of evidence that's high quality, and you ought to put the right piece of evidence together with the right survivor at the right time to create this state we know of as health. And so in reality, as you might imagine, this is so simple to be kind of ridiculous, and I'm hoping to illustrate a couple spots where we do know things that might help us make better decisions. So if you take that schematic about how things ought to work for survivorship, what does it actually look like? So I would encourage you all to look at this guideline that was published just last month in the Journal of Clinical Oncology. And it's a collaboration between the American Cancer Society and the American Society for Clinical Oncology, and they called it the Breast Cancer Survivorship Guidelines. And it was a direct response to the Institute of Medicine's suggestion that we ought to have specific guidelines on what we ought to do for people. Breast cancer, you might see if you look in this literature, truly leads the pack in terms of survivorship guidelines, and for a lot of reasons. But in reality, we are following the pathways created by the breast cancer physicians. And so what these guidelines were a systematic review by a multidisciplinary panel. So they have a room full of experts, and they looked at the literature, and they sort of came up with recommendations as best they could. And so, for example, this is one that you probably are aware of already, that they recommended that, in the Institute of Medicine and now implemented by in the breast cancer guidelines, that a survivorship care plan be created. So that's a document that is provided to the patient and their physicians that describes the treatment, describes what needs to happen in the future, what risks are known to come up in the future, etc. That ought to be written down and provided to the patient, and that patient ought to provide it to their primary care provider and anyone else who needs to know. And so this systematic review described a variety of sort of domains, surveillance for recurrence. What should we do as what are the right surveillance tests? What are the wrong surveillance tests? How do you assess for late treatment effects? What kind of assessments are relevant? Which treatments predict which assessments that need to happen, etc. They talk about care coordination. And they will, in the very first, literally in the abstract of this, on the first page, they basically say fairly little of this comes from high quality evidence. So the vast majority of the time, they were saying, look, this is just what we think of as a room full of experts. We've seen these patients before. This is what we think is important. But we don't really have the evidence to back that up yet. And so this is, I think, a great thing to look at as to say, here's where we are starting, because in the head and neck world, it would probably be the same. We don't have a specific guideline for the head and neck world, but it would kind of look like this, and it should focus our efforts on where we ought to be going as we plan survivorship in the future. So head and neck cancer survivorship, of course, as you all know, having seen head and neck cancer patients, is different from survivorship issues related to breast cancer. There are treatment-related issues that we all know. I mean, you see this on a day-to-day basis. Patients with xerostomia after radiotherapy, patients with tinnitus after chemotherapy, patients with trismus after complicated multidisciplinary treatment of oropharynx cancer. There are ones specifically related to the tumors that you wouldn't see in other kinds of body sites. Dysarthria, cranial neuropathy, the presence of a stoma after treatment of advanced larynx cancer, etc. And then, even specific to head and neck cancer, these are issues that have been described in the literature again and again. Suicide risk and depression. It is sky high for head and neck cancer patients. It's different than it is for breast cancer patients, or for prostate cancer patients, etc. The things we do to patients and the things their cancers do to them prevent them from returning to work at a significantly higher rate than we see in many other cancer survivors. And so including that in our healthcare, I think it makes sense to say this is a healthcare issue for these individuals. And of course, as you know, alcohol abuse affects patients on their way into treatment, during their treatment, and on their way out of treatment as well. And so, we ought to plan for that. And so what this tells us, survivorship is complicated and multifactorial. There are lots of things that go into it. It means a lot of things. So ultimately, how do you make decisions about what to do? And it comes down to what you say, how do you maintain health? What is it? What are the things we need to do to maintain health? And of course, you need to know what we mean by health by doing that. One of the things that we frequently think of when we think of survivorship is the implementation of screening tests. So what I think of when I use the phrase screening tests is testing that's done in the absence of symptoms. So we are testing people that we seem to have no signs or symptoms of a problem, and we are testing for that problem to identify whether some abnormality will show up on the screening test, and then we think something else will happen afterwards. So the United States Preventive Services Task Force is probably the biggest governmental organization here in the United States that manages data related to screening tests. You've heard about this in the news when they talk about when to start offering routine mammograms to women and a variety of other things. And so the USPSTF is a group of experts, again, they come together and they, having reviewed the evidence and the literature, and they have a set series of criteria that they use before they create their recommendations. And their criteria are based on the size of the net benefit versus the size of the net harm, and they account for the uncertainty, they account for the strength of the evidence. I think this sort of, and I'm not going to speak on this any further, but I think one of the themes that kind of underlines this whole issue of survivorship is encompassed right there in that bullet point, whereas there is an enormous difference at times between how we make decisions for population health and how we make decisions for personal health. And we hear a lot about population health, we hear a lot about personal health here as we're all physicians in this room. It is not 100% clear in anybody's guideline how to merge those two things when they lead us to different conclusions. And I think that's a fascinating issue and probably something we all ought to spend more time thinking about. In any case, moving on to screening tests, I put up these three words, burdensome, prevalent, and treatable, as the criteria for a problem that might be amenable to a screening test. So by burdensome, I mean it has to be a real problem. There has to be some sort of meaningful health outcome. And again, I'm defining words in reference to other words that I haven't defined. But some sort of meaningful outcome that will be worse if we don't find some specific problem. It has to be prevalent enough. We all know, we learned in medical school about Bayes' theorem and the sensitivity, specificity turning into negative predictive values and positive predictive values. For a disorder that is not very prevalent, your test will have to be very, 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 very good for it to help you. And so most tests aren't that good, and so you have to have a disorder that's prevalent enough for your test to make it a useful test. And it has to be a treatable condition. There's no point in doing a screening test for a condition that you can't treat. And more specifically, the treatment that you offer that patient after a positive screening test has to be better in some measurable way than what you would get if that patient just waited till their condition became symptomatic. And that's the criteria we ought to use before we say this is a screening test that we ought to implement for everybody. So here's an example. There is a high prevalence of hypothyroidism after radiotherapy of cervical nose. And there is, if you've seen patients who come into your clinic or crawl into your clinic with a TSH of 90 after radiotherapy, they are not right, and they feel not right, they feel ill. You can do a test that you can interpret fairly straightforwardly. There's some disagreement on the specific interpretation of TSH sometimes, but when the TSH is 90, it seems pretty clear that that's abnormal, and we have very effective, inexpensive, and life-improving treatment for that. So this is a screening test for which I would say it makes sense to do this. The USPSTF has not described a specific guideline for studying thyroid function and head and neck cancer survivors, but I bet if they did, it would come up pretty good. Has anyone ever heard of the Bell scope? I think that may be a good thing. The Bell scope, it's depicted in that diagram right there. It is a device that uses the phenomenon of autofluorescence, and it evaluates for oral neoplasia. And in theory, it can find a dysplastic lesion that you couldn't find on just simple oral exam with white light evaluation. So the problem and the Bell scope, as you can see, I guess it's hard to tell in that picture right there, but it is marketed to dentists, not marketed to physicians. It's marketed to your dentist, and your dentist will buy this device and will charge you $35 to say, would you like me to tell you if you have oral cancer or not? And then most people will say, yeah. And then write them a check for $35, and this is what happens. So the problem is that across the population, the incidence of oral cancer is actually fairly low, especially in comparison to the specificity of this test. And so if we look at everyone's mouth with the Bell scope, you would find abnormalities in a fair number of patients. And the vast majority of those patients would be referred for biopsy. So the question truly is, do all those patients really need biopsies? Are we really creating health by doing this? I don't think the data looks very good for the Bell scope, and that's why I say it may be a reassuring thing that no one has heard about it, because you haven't received referrals for management of patients with abnormal Bell scope exams. It can be complicated. The patients are unsettled by it. I've had a couple of these patients. No one really knows what to do with this information, especially when there's no visible abnormality like it is most of the time. So what I'm really going to spend most of my talk on here is about whether we should screen for lung cancer. I'm not sure.
So it's good you've memorized it.
Yes. And so what we'll talk about is the epidemiologic data around lung cancer and head and neck cancer survivors. And then we get into how we manage priorities for individuals and populations. I'll spend a fair bit of time talking about the harms of screening, because that's one of the most relevant questions when we think about whether we should do it or not. And then finally, we'll end up with this philosophical question about what we mean by health. In order to do this, I guess what I'm going to come down to is that you end up having to have these complicated conversations with patients that you just said you're disease-free at 3 years, everything looks great, now let's talk about the end of your life. And they will say, that's not what I came to talk about today, it turns out. So, the reason we talk about screening tests for lung cancer is that there was a trial published called the National Lung Screening Trial. Anyone heard of the NLST? It was published in 2011 at first, and the additional data came out in 2013. And they took patients that were at high risk for lung cancer. So they started with a population in which the prevalence was thought to be about as high as you could reasonably get in a large population. These are patients that were 30-pack-year smokers or more, either patients that were currently smoking or had quit within the last 15 years. And they were aged 55 to 74 at the time of enrollment into the study. And the selection of those ages comes from the fact that they are old enough to have had a higher incidence of cancer. Cancer is a disease of aging, so your population incidence is higher for an older population. And then they stopped at age 74 because they start thinking, well, your people are going to benefit less and less on a population level by identifying these cancers. So This was a randomized study in which patients either received an annual low-dose CT of the chest without contrast annually for 3 years, and the comparison group received an annual plain chest radiograph. Again, these are patients that have never had cancer before. That was an exclusion criterion, was a history of any malignancy. It was done in 33 hospitals around the country, and in each of these hospitals, the trial itself did not specify what should happen for patients with positive findings that were labeled positive by the radiologist. There was clinical follow-up as appropriate by the treating physicians. That was published in 2011 in the New England Journal. So here are the results. There were 26,000 patients in each group, so this is a massive undertaking. There were 1,000 cancers in the low-dose CT group and 941 in the chest X-ray group. So there were more cancers identified by the CT group. It's not an order of magnitude. There were only 10% more. There were more lung cancer deaths in the chest X-ray group, 440 versus 356, a difference of about 90, more deaths in the chest X-ray group. So this is looking pretty good for screening. So screened populations are different. This is a principle of epidemiology. When you start looking for cancer in asymptomatic individuals, the cancers you find are different than the ones you will find in an unselected group of the population. So 53% of the patients in the low-dose CT group were stage 1A through 2A versus only a quarter of the patients in the chest X-ray group, this is starting to look pretty good for again, it's still looking good for screening tests because you say, this is great, we're actually finding stage 1 cancers rather than waiting for the chest X-ray to pick them up at stage 4. So this is perfect. So, but look at this. This is kind of interesting. This is where things start to look more, bear more thought. So it turns out that of the cancers identified in the low-dose screening group, 110 of those were bronchiolo-alveolar carcinoma, which is known to be a fairly slowly progressive cancer that lots of people may be walking around with at age 70 after a lifetime of smoking. And it turns out that there are 70 more cancers in that group that were these indolent cancers that it's hard to say, yeah, I really needed to find that at that time because it's going to change this patient outcome. So although we've got 90 more cancers in the chest X-ray group, 70 of them are ones that we say, it's hard to really say if I found that cancer that I've changed that patient's outcome meaningfully. So let's move on to the harms of screening. What are the physical harms of screening? Of course, you've got to do all the stuff that comes after a positive screening test. So if you look at this group, the low-dose CT group, 26,000 patients. They got an annual chest CT for 3 years. If they were diagnosed with cancer during that time, they probably didn't stop having CTs because they started having treatment and should reasonably not be considered in that. So you're talking about 70,000 CTs and then 8,000 follow-up or 9,000 follow-up diagnostic quality CTs from there. So we're talking about 80,000 CTs that are done in these patients versus 3,000 CTs. So you're talking about a difference of 5,000 CTs that were done in one group and not done in the other. We're starting to add up to some harms. There are almost 500 more invasive, like real surgery procedures done for these patients in the low-dose CT group. Again, some of them, these are in workup, not to treat cancers, but these are in workup of the abnormal findings. So 500 more major procedures. There were 184 complications after diagnostic procedures, either pneumothoraces after CT-guided biopsies or surgical complications. And then there are 50 more major complications after these diagnostic procedures. So we started with finding 90 more cancers, but we've got 50 more surgical complications and about 75,000 more CTs. It's complicated, right? So when we look at the psychological harms, which is where I'm going to come up at the end of my talk, positive screening tests, 24% of screening tests were positive. That's a lot. I mean, it's 1 in 4 chance that the screening test is positive. That's not a hallmark of a easy-to-interpret test. And 96% of those were false positives. So is this easy for a patient to undergo? I'm gonna come back and talk to you more about that, but I think that's a big issue here. So let's go talking about lung cancer. Now shifting away from these otherwise healthy individuals that were enrolled in the NLST study, switching over to the head and neck cancer patient population. So we talked about how the outcomes after diagnosis are critical to the effectiveness of the screening test. It means that we have to be able to treat these patients for cancer. And I didn't show you this slide, but there was an improvement in lung cancer-specific mortality in the NLST. So fewer people are dying of lung cancer after doing the low-dose CTs. But the likelihood that we can cure them of their cancer and keep them alive for longer is important when we decide whether or not to do the test. It's not just about finding cancer, it's about finding it and keeping people alive or improving some other meaningful outcome. So our lung cancer outcome is the same in the head and neck population that we see in our clinic all the time. So to answer that question, we can go to the SEER database. And this is where the big data thing comes in. So the SEER database is an NCI-supported repository of comprehensive cancer data that's based on geographic populations. So I showed you down at the bottom, it turns out that you and I we both live in SEER databases. In California, it's by county. It happens to be the entire state of Iowa, are 2 of the 18 geographic regions. There are 16 others around the country that encompass 26% of the United States population. And it has very high standards in comparison to your average state cancer registry that doesn't participate in SEER for completeness and accuracy. So you can, as this is as good as data gets in the US, the National Cancer Database is another repository which is larger than you can get from SEER. The problem is that that is hospital-based, it's not geographic-based, and so you don't know which patients were in that physical area that went to a different hospital. And so you don't have a denominator to create a real epidemiologic measure. So not as useful for some specific questions. So what about the incidence? Are we seeing more cancers in this patient? We know the answer is yes. There's lots of smokers, there's lots of other causes and reasons for which head and neck cancer patients also could have lung cancer. And so if you compare population incidence of lung cancer in head and neck cancer survivors, and you compare that to an age, sex, and year matched population cohort from the general US population, you can do this using SEER data. For patients with survivors of oral and pharynx cancer, you would expect 480 cancers in the number of patients that are in the SEER database. You actually have almost 4 times as many in actuality. For patients with larynx cancer, it's 3.7 times as many cancers as you would expect in an age, sex, and year matched population cohort. So we are, as you would expect, seeing more cancers in the lung in the group of head and neck cancer survivors. So let's move on to cancer survival. Do head and neck cancer patients do as well as the NLST patients would be expected to after a lung cancer diagnosis? And so again, we went back, this is a paper that I published last year, that we looked for patients with lung cancer diagnosis that were diagnosed between the ages of 55 and 74, just like the NLST group. There were, we only selected patients that were diagnosed at early stage lung cancer, stage 1A through 2A, which were 50% of the patients in the NLST. And then we identified 2 cohorts. One cohort that had no other cancers other than their lung cancer, and one cohort that had a single head and neck cancer that was diagnosed greater than 1 year before. And we chose that 1 year mark to eliminate the phenomenon of synchronous metastasis. And so we've assembled these 2 cohorts, and I can talk to you about that later, but I won't spend a whole lot more time on it right now. Then what you find is that, as you might expect, in important ways, the lung cancer patients, the head and neck cancer patients were different from the patients that only had lung cancer. That more of them were male, which is an adverse risk factor for lung cancer. More of them had squamous histology, again, an adverse risk factor for lung cancer. So the kinds of cancers you find in head and neck cancer survivors are different from the kinds of cancers you might find in the NLST group, in the group of unselected high-risk smokers. And those adverse risk factors are present systematically through this cohort. And if you look at their actual survival outcomes, this is observed survival, that there is a meaningful difference, that the patients, after you identify lung cancer in a head and neck survivor, 50% of those patients live 22 months, and the other 50% don't make it that far. In patients that have never had another cancer, that median survival is 38 months. And I would say that that's a meaningful difference. That's a difference that patients would want to know about, because they might think about that differently if you have a patient that isn't going to do that kind of thing. So the question is, based on this data, should screening chest CT be a routine for head and neck cancer survivors? That also comes down to not only the data about survival and the incidence of cancer, but what about what happens afterwards? The implementation of screening, the devil is in the details, right? So the NLST was done in large academic centers. Many of them were NCI designated comprehensive cancer centers. They had expert radiologists. They had expert pulmonologists. They had expert surgeons. So every step of that process is worked in those patients' favor. The question is, would we expect to have the same findings when we translate this data into the community? If you've got patients in small hospitals across the country that are getting their chest CTs and then moving on to somebody making a decision about whether a nodule can be safely observed for another 12 months, or whether it needs a CT-guided biopsy, or whether they need a portion of the lung removed, how many people would consider that we'd have just as good results when this is implemented widespread in the community? No hands. So, and there is some amount of data, again, that all of this data is fairly new, but at least preliminary experience as far as I found there are more positive screening tests, which means that radiologists in the community are less likely to say, yeah, that's nothing. They're not going to say that. They're going to say, I don't know about that, we better do another scan, which is a big deal. There's a higher false positive rate, which means they say, yeah, there's something there, but it turns out to be nothing after a bunch of diagnostic tests. There is actually, turns out there is some literature that the diagnostic complication rate, the rate of pneumothorax, the rate of complications from lung surgery, bronchial pleural fistula, and prolonged hospitalization, ICU stays, things like that, are noticeably higher in the community than what we expect in those super specialized centers of excellence. So what about the cost effectiveness? Cost effectiveness literature hinges on the phenomenon of the quality adjusted life year. And so the question is, how much does it cost to get a given amount of benefit? And benefit is measured in a fairly broad way in these patients using complicated instruments, but they allow us to compare one intervention versus another. And so using NLST data that's been published, they judged that there would be $81,000 expenditure on healthcare for a single quality adjusted life year. And that's in the group as a whole. If you look at just the cohort of people that have quit smoking, again, we had former smokers within 15 years, $615,000 per quality adjusted life year. Some of this data has been modeled on the kind of results we should expect when this data is implemented in the community, and as you might imagine, the expenditures per quality adjusted life year are even higher. So one sort of fairly interesting response that was published to the NLST recommendation by the American Association of Family Physicians, a pretty big advocacy and big organization in its own right, is that instead of spending money on thousands and thousands and thousands of CAT scans, maybe we ought to get people to stop smoking. And we will improve their mortality that way. There isn't, of course, randomized data that allows us to say this is definitely going to work, but it should be something we ought to be thinking about. What about the harms of screening related to radiation doses? This is an interesting study. So a low-dose chest CT provides a 2 millisievert radiation dose. That is in comparison to the 8 millisieverts of radiation that patients having diagnostic quality CAT scans receive, CAT scans of the chest, that is. And so this is a study that modeled a lifetime of screening starting at age 55, as you might expect based on the data. And if that 55-year-old is screened for 20 years, and occasionally, like lots of patients do, have findings that are not known to be false positives until you go through the rest of the evaluation, 20 years later, that patient will have received a radiation dose of 280 millisieverts. That's a lot. In comparison, the average nuclear power worker around the world has a lifetime dose of 19 millisieverts. The best studies of the atomic bomb survivors in Japan, 40 millisieverts lifetime radiation dose. This is a lot. Now, in patients who have received therapeutic radiotherapy, it's not a lot. And that should be acknowledged, but this is important. If you look at, there's an increasing amount of attention being paid to radiotherapy or radiation dose resulting in induction of cancers, 0.3 induced cancers per 1,000 patients screened, according to the authors of this study. There were 27,000 patients in the NLST. That's competes with the number of cancers that we've identified, lung cancers identified and cured, versus the number of cancers we've induced by the screening modalities. These are big numbers. So, and what about the other harms? This is what I'll get into here in the future, but as we know, your radiologist doesn't know what's on a scan until you tell them with your clinical information what's on a scan, right? How often have you said clinical correlation is required? They are Bayesian at heart. They need to know their pre-test probability before they can tell you the post-test probability, as they should be. That's how we ought to think about diagnostic tests. And we don't give them clinical information. These are screening tests, so by definition, the patient is asymptomatic and there are no other known findings. Indeterminate and inconclusive findings are par for the course. I have actually almost never seen a negative screening chest CT. I live in a place that's sometimes known as the histoplasma belt. There is almost no such thing as a normal chest X-ray in the state of Iowa. Everyone has calcified nodules, everyone has small nodes. This is a real issue. Nodules too small to characterize is almost sort of like, I'm sure they have that on Smart Set and Epic. Psychological outcomes, and that's what comes down to these issues of false positives. So it turns out in this literature that we probably don't know very much about, and I didn't know much about until I started thinking about this. Severe psychological distress is more prevalent in cancer survivors than in adults without cancer. That shouldn't be terribly controversial, but maybe it is a little controversial when you see this literature that says that actually is the case 15 years after diagnosis. This is not an issue of acute psychological distress that gets better when you say, it turns out the cancer's all gone, everything's good, margin's negative. The patients don't turn to normal right afterwards. There are risk factors for severe distress, things like current and former smoking. We'll get into that in a second. Younger age, they know that there's a longer time during which they can become a cancer patient again. Patients that are less educated, and patients that have comorbid conditions. So there are things that we can use to predict that psychological distress. But one of the things that we are really talking about when we talk about psychological distress is fear of recurrence. This is, it turns out, at least in one study that was a well-conducted study from the Liverpool Oral and Maxillofacial group, the most common issue that patients think about on their way into a clinic appointment with us. So this was a study in which patients on their way in to see their oral cancer provider, their surgeon, in follow-up, doing well from cancer, they were provided a survey on their way into clinic. What are you thinking about? What are you worried about? What kind of issues do you wish your provider, your care provider, would address with you today? So it turns out that fear of recurrence was by far the greatest issue on that list. It's greater than xerostomia. I mean, I'm sure your patients are the same as mine, that xerostomia, pain, dysphagia, these are the things that we spend the vast majority of our follow-up visits talking about. It turns out that if you really ask, if someone else other than their care provider asks them, what are you interested in? It's actually fear of recurrence. And this is in long-term survivors as well. It's not just within that first year. This is a long time down the road. My own colleagues at Iowa have done some of this research as well. They used a validated tool called the FCRI that is targeted at measuring fear of recurrence, and it can be dichotomized in a valid way. My colleagues have also published something called the HNCI, the Head and Neck Cancer Inventory, as a widely validated head and neck cancer specific quality of life instrument. And so 138 patients were involved in this study in which we basically said, tell us about your fear of recurrence. Is this an issue for you? And it turns out that very directly they said, yeah, for patients that are, that fear of recurrence is inversely correlated to quality of life. And importantly, it is particularly strongly correlative to the social disruption domain of the HNCI. So there are a variety of domains, like in many quality of life instruments. And so it particularly is acute in patients that feel that the cancer has driven a wedge in the middle of their life in some important way. And of course, this doesn't tell us which came first, or doesn't tell us the arrow of causation, but it should be something we ought to think about. Fear of recurrence is also greater in current smokers. I mean, this is an interesting thing. I mean, smokers all know that smoking is bad. I mean, you don't really find patients that think it's a good idea. And there are complicated issues by which patients remain smokers for a long period of their lives. But it's the smokers that you think, these are the ones that have the motivation to do something different, their fear of recurrence, but it turns out it's not like that. That fear of recurrence is greater in current smokers. So what does this really mean? I'm going to get back to this in a second, but I'm going to phrase the rest of my talk here, a few more slides, with my observation in my clinical practice. And this is not based in data, but this is based in my thought, seeing these patients on a day-to-day basis, that it's the process of ordering tests and discussing not just any results, but the indeterminate results that are 25% of our screening diagnostic tests, our screening tests, that meaningfully increases fear of recurrence in a significant proportion of our patients. And I think we are not always healthy people by ordering these tests. So, when it comes to diagnostic tests in particular, there is literature about that too. Not in head and neck patients, but in the gynecologic oncology patients, that a very large proportion of patients described an out-and-out fear of future diagnostic tests, the ones that they weren't even having, ones they weren't even scheduled, but they knew that they were going to have another follow-up PET scan next year, and I'm worried about that right now. It causes me trouble. There is psychological distress that's measurable, that rises within 2 weeks of an office visit in patients that are, again, doing well, not patients that are doing poorly, that is relieved for weeks afterwards. So the act of coming to clinic to see us is not really a benign thing from the perspective of psychological health. And this is, I think, where it all comes together. This is a survey of adult melanoma survivors. Melanoma patients, as you might imagine, they have been talked to for a long time about how they have this aggressive form of skin cancer that is associated with a measurable mortality and this is a bad problem to have. Most of them do not do skin self-exams as often as been described to them by their physicians. So they know that they've got melanoma, they know they've got this skin cancer that could come back and kill them, but they don't really choose to spend their time looking at their skin. However, they have a very high incidence of having their children examined in the absence of any guidelines suggesting that you should have your children examined when you were diagnosed with melanoma. So what does this really mean? What is going on in their minds when they say, I can't bear the thought of looking at my skin, maybe I might find something, but my kid, who knows what's going to happen to them, but we need to get them into a dermatologist yesterday. There are no guidelines to support that. And I think what this tells you is that there is this real concept that is actually, it turns out, has a word called illness perception, that is a phenomenon from the psychology literature, and it is a concept by which, when you give a patient a cancer diagnosis, they go through a complex series of mental processes which are initially cognitive. They think about it, they make an understanding about what it means to them, why they got it, etc. And then from the cognitive representation in their minds, they have these affective processes about really how does this impact me and what do I think about it and what does it make me think about the rest of my life. And of course, that's something that they do in our absence. We try to direct this process by giving them resources that we think are helpful and are appropriate to their level of understanding and their ability to read and benefit from those resources. But it's something that happens in our absence, in reality. And it turns out that we can measure by patients with different kinds of illness representations in their own minds that we can predict quality of life on the basis of the way that people think about their own disease. And people think differently about their belief and their likelihood of recurrence and their attention to their own symptoms, whether they're really, and no doubt we've all had patients that walk in with enormous 10-centimeter neck masses on the other side, and you think, why didn't you tell me about that? When this has clearly been there for a long time. Clearly, we could have done something about this 6 months ago, but and there are other patients that come in with no apparent neck mass, and they won't allow you to reassure them that there's really nothing going on. There is a complicated representation that we have, and I think you really have to get into that process, and this is something that we really need to study to understand better in order to bring people who no longer have cancer to the state that they would think of as health. This is underlined by one of my favorite studies. This is a study of, it was a survey that was administered to two groups of patients. One group of patients that was just diagnosed as having a head and neck cancer, and the other group was young, healthy people that have never had cancer diagnoses. And it turns out, they asked what their priorities would be. Would you want this? Would you want that? Would you want the third thing? And it turns out, in a few fairly meaningful and impressive ways, people with cancer don't think like people without cancer. So you have lots of, if you talk to your average 22-year-old college student, yeah, would you have your larynx removed if I said there were no other way to treat your cancer? I would never want that done. I would never want that done. If you talk to someone with an advanced larynx cancer, here's what we can do to cure you, here's what we can do that wouldn't cure you, there's much less of a, it's not the same, let's just say it that way. Obviously people still think about it, but they don't think of it the same way. Having no pain. Lots of cancer patients would say, do whatever you have to do, I want to be cured of my cancer. Fine, we'll deal with the pain. I don't like pain, I don't look forward to it, but that's not the main issue. And lots of other, your average college student would say, yeah, pain would be terrible. I would never want to live with that kind of pain. It's not the same when you actually have cancer. And the other thing that actually came up in that study was keeping a normal sense of taste and smell, which is different, meaningfully different when you ask this to cancer patients and you ask it to non-patients. And and again, my focus in my talk is not about how to deal with this, but I think this gets at that same illness perception issue. That when patients ask me, what would you do? What would you do? I would say, it's hard for me to answer that question. And the reason that it is that I haven't gone through that process of this cognitive and affective process of representing this illness in my mind for how I got it, and what it's doing to me now, and what it's going to do to me later. And that's why we are not the same as patients. We can't really answer that question. And I think that it makes sense, every bit of sense, that this perception impacts their survivorship, just like it impacts their choices about cancer treatment. And I would say that although this prevents opportunities for us to study this, when we can try to get at people's illness perception and what we need to look for to identify what it means for those patients to be healthy, because it isn't an organic thing, it is actually almost as much psychological as it is organic. It requires us to have these complicated conversations that are longer than the conversation it takes us to explain the results of an equivocal screening CT. about whether we ought to do it or not. And I think it makes sense. I think the only time to do that is before you order the test, because there are lots of patients that I have found would say, that doesn't sound like that's going to keep me any healthier, and I'm not sure that I can agree with that. So I know that some people will object to say, look, I get chest imaging in these patients to evaluate for metastasis, and that's, we're not, so sure, looking for a second primary lung cancer is one thing, but we're going to do these imaging tests anyway because these patients are at risk of mets. But my opinion about that, and again, this is an opinion, there's no data about this, but it requires the same assessment of the patient's thoughts. You're going to find a metastasis, which is actually quite unlikely to be a salvageable situation. Sometimes it is. Maybe in the HPV era, I ought to be thinking differently, and to some extent we are. But whether or not we look for a disorder that is, by definition, asymptomatic and incurable, I think requires a complicated conversation. It requires you to have that conversation before you order the tests, and not afterwards. So again, we started with this very, very, very bare bones schematic of survivorship, but ultimately I think that attitudes play a big role in how this ought to go, and then illness perception plays a big role in how the attitudes get predicted. And I think that we need to understand each individual patient. And of course, there are clinical ways to do this that are different and easier than the way that psychologists would do it. But I think we need to have a better understanding of patients as we start this analysis of survivorship. So there are these interesting investigational opportunities related to survivorship that will allow us to do better by our patients in maintaining their health. There are decisions to be made about health maintenance, and that they can be illuminated by epidemiologic data and other sources of big data that can be powerful tools in giving us and setting hypotheses for what might happen on a population level that then need to be translated on what we do on a personal level. And ultimately that translation comes with these complicated conversations that we have to have. And I don't think there's a right way to avoid it. My practice is basically, I tell patients that screening is right for some people, it's not right for everybody, and that we ought to talk about it. It's not always an easy conversation to talk about end-of-life issues in a patient right after you've told them that they're a 3-year survivor and everything looks fine, but ultimately that's what we have to do, and I think as oncologists that's our job. So, thanks for your attention. I'm going to stop and take questions. Yes, please.
So far, you've mentioned the cancers, and the active factor there was the risk of smoking.
Yes.
In the 30s, there was a big push on dietary. Why is dietary not pushed as much as, say, removing smoking, or just take certain dietary supplements that affect the immune system? And there are statistics to show that patients who are on certain anti-inflammatories, vitamin D, etc., for instance, say colon cancer, do significantly better.
I think it's a good question. I would say that the reason that I think that we probably don't see it because the strength of the evidence is not as great as the evidence between smoking and cancer, and lung cancer, and even head and neck cancers. But I think it makes sense to include all those, as we make broad assessments about what we ought to be telling people to do. We ought to be following the evidence.
You mentioned when you talked about the lung cancer screening trial that the patients that were being screened had more indolent forms of lung cancer, and yet when they did the analysis, patients that had screening had better survival. Can you comment on maybe the effect of lead time bias on that?
So I think the issue that we're getting at is that you are finding cancers in patients that would have been identified had we done more traditional, not the new CT stuff. We would have found those patients at a later date. So, and that's, in some way, that's the big argument towards screening, is to say, I can find this cancer at a stage 1, whereas if I waited 5 years, I would find it at a stage 4. And that's exactly what a proponent of screening would say, this is what we're doing. But I think it is frequently a little bit more complicated. There is, for example, you can make a similar argument when we look at PSA in prostate cancer, which has actually turned out to be a very complicated calculation to have to make about most older men with prostate cancer. There's an analogy that I've heard that maybe living in Iowa, we make analogies related to what we know. So there's the analogy about a farmer in a barn, and the barn has pigeons, and it has rabbits, and it has turtles inside it. And the farmer builds a fence, which is the screening test. The screening test will keep the rabbits inside It doesn't matter if you build a fence because the turtles aren't going anywhere, and it doesn't matter because the pigeons are going to fly over it. The rate of small cell carcinoma was the same in those two studies. The rate of stage 4 cancers were similarly high in those two studies. So you're right, that it makes you think that we are finding things that otherwise we would find later. Yeah, I think it does. It is also impacted by the fact that the NLST was a 3-year study. It was a time-limited study, and then the study period ended. The recommendations that have come out about lung cancer screening by USPSTF and the American Cancer Society actually now advocate, and even with Medicare, by the way, advocate lifetime screening. And so that's why it is relevant to talking about 20 years of screening, as I mentioned in the radiation dose slide. But maybe you're going to find cancers in a 20-year program that you wouldn't find in a 3-year program.
Do you think the difference in survival between the two groups could have been probably the difference it took for the patients that were identified earlier to progress to the point that the other patients were identified?
I think it makes sense to think about it that way. I think it is not as cut and dried, I think, as the proponents of screening have described it on the basis of that study. And also the outcome of that study, and that study actually ended early after it met particular efficacy criteria. The outcome of that study was based on lung cancer specific survival. So it isn't observed survival. It isn't another measure of health, but it is who is dying of lung cancer and who is not.
You've established that it's far from clear that the recommendations to screen such patients is economically wise or even safe, given the risks. For prostate cancer, for PSAs, as you mentioned, the life year saved, dollars per life year saved is probably in 7 figures, and yet it's still done and often still recommended, although that's 20 years later, people are only now beginning to pull back from that a little bit. How long is it going to take to pull back from this?
I think the pendulum is probably swinging the other direction at this point,
Right.
With Medicare within the last couple of years saying, after a fair bit of public outcry, that was, to be honest, it was raised by radiologists and thoracic surgeons. And again, not that everyone is, following their bottom line, but it makes sense that they think about things that way. I would say that the pendulum is not swinging towards doing less of this. It's probably swinging towards doing more of this, especially because the guidelines are now well outside the scope of what was in this study. The study was again published patients aged 55 to 74 for 3 years. The guidelines now say 55 to 80 for a lifetime. And they also include not just former smokers, but people with a history of head and neck cancer. And so we are, on the basis of data that I would say it actually makes sense not to screen these patients.
No, that's my point. In other words, with the data clearly can be questioned, so the question, what's it going to take to get the overreaction, if you will, at best, rethought out?
It's a challenge, and you know what happens when people suggest that we should do mammograms starting at age 50 rather than age 40, and those folks are probably honestly following evidence and didn't feel like they were in the middle of such a bomb. The survivorship world is not as pushed by a single organization like it is in the breast cancer survivorship world, and so it makes me think there may be room for data in our world. I hope there is. And I think it makes sense for us to study these patients in cohorts. We ought to build a cohort of patients that are having screening tests done long after their head and neck cancers have been cured or somewhere in that process, and ask them about whether we are overall doing them harm or good by doing so.
I have 2 questions. In your study where you looked at lung cancer and head and neck patients, what role did regularly scheduled or like a normal 5-year post-cancer follow-up PET scans play in terms of maybe increasing the incidence of detected lung cancers? Basically, did PET scans contribute to the number of lung cancers you found in that group, or were your data so kind of long-term follow-up that kind of fell out? You were just talking about making screens.
So in the data that I published, the paper that I published last year using SEER data, you don't have information on how cancers were diagnosed. So we don't know if it was in PET or if it was CT or patient screening, or we have no idea. We just know when the cancer was diagnosed and what the treatment was and what the survival experience was. So that data came up to, I think, 2011. Was the 1970s to, or I'm sorry, I probably started in the 1980s up to 2011. So, PET scans are, by the month becoming more and more commonly used. And so I would say it probably makes sense that fewer than back in 2011 were diagnosed with PET, but I don't have data on this.
My second question is, I'm not a resident anymore, but I remember how slammed head and neck clinics can be. What forum do you think is the most appropriate to have these difficult discussions with patients, and who should be having them? Should we, as a laryngologist, be referring them to survivor groups, to cytologists, to other topics? Or is it, do you really, you said in the end, do you think it's the oncologist's job to have all these conversations? Time constraint wise, what do you think?
Yeah, I think that's a great question. So the solution that we have in our department is we have a specific head and neck survivorship clinic. And we moved many of our head and neck cancer survivors into that clinic. We have a PA that runs it. She has the ability to have some more time with patients that we have less of. So for patients that are, and we typically refer patients into the survivorship clinic at 2 years of cancer-free after last cancer-corrected treatment. I would say that if it definitely comes up in patients before that time, and I think it is the, when I refer to myself as an oncologist, I think it means that I am, my goal is to have that complicated, nuanced, and long-term relationship with patients about which I'm in a position to give them bad news and to tell them something that they don't want to know. And I think it's my job.
And I just have one question for you.
Yeah.
So for an advanced stage non-smoker HPV patient, what sort of, do you guys have a common protocol you guys use, or is there a lot of variation for how you would screen these?
Screening patients. So I will say that I have, this is my way of thinking about it. My colleagues don't necessarily agree with me. And so there are lots of patients who come back having had chest imaging ordered by another member of the multidisciplinary team. So I would say that my thought is to do it annually in patients that meet those the NLST criteria, so people within the ages of 55 and 74, current or former smokers, and those are the ones that for whom I would recommend doing, or I would have the conversation. And I would say, look, we can do this, or we can not do it.
And then non-smokers, the HPV positive.
For non-smokers, I would say that is, we have sort of been doing what we always used to do. So I would say that in many of those patients, I still have that conversation. I would say I don't have as much data behind it. To be honest, we found a lung cancer. Actually, we found a MET, an oligo MET. That was a single isolated lung metastasis in a 48-year-old guy that had done very well for 2 years from his tonsil cancer. I think it makes every bit of sense to have operated on him. So he is, I think where that patient changes my practice, I would say I'm still on evolution, because it makes sense to think differently about it.
Awesome. Just one last question. It's coming from Iowa. The California primaries come out in June. Is it important for us to meet each candidate 5 times, or is only 4 times enough in the coffee shop?
I think that, so we had a field of, I think, it was a bigger field, and I'm glad I spent not very much time.
Sure.
That's good. In patients with piriform sinus cancer or base of tongue cancer who have a higher risk of having lung metastasis, would you do a total laryngectomy without knowing the status of their lungs?
I would, if it helps me make the, and I would, if it helps me and the patient make a decision about whether to proceed with surgery or not, then yes.
So that hasn't changed.
But if the patient is symptomatic and would say, look, I am, for a healthy person with a terribly symptomatic, non-functional larynx T4 cancer, I would say, if you would consider surgery, I would say let's do surgery, and we'll consider the chest imaging afterwards.
For palliation. Right.
Yeah. I mean, if I would do the test if it makes a difference in my next move.
Yeah.
And if it makes a difference in my third move, I would say let's do it.
So we're not going to get any pre-op routine chest x-rays on cancer patients, according to your protocol.
Asymptomatic.
Asymptomatic, right.
I don't routinely do it.
Okay. There goes CDCs. That too. No, I'm being an nihilist because for many years,
Yes.
those of us have been doing this all along
Yes.
without any rhyme or reason except what we were taught to do. And if we didn't have a chest x-ray, by the time we got to the OR, we got reamed out. Right?
I think he's saying in the situations where it wouldn't change your treatment algorithm. So a lot of times you wouldn't necessarily operate on that patient most
Right.
of the time. So in those cases you would.
Right. And they're not going to be symptomatic with their lung.
But also, they're different. If somebody had a chest X-ray, an infiltrate, you might want to know that before you operated, so if you see it post-op. So it's a little bit more complicated.
Yeah, it's not so cut and dry.
But the other way to put the question is, in a routine pre-op or pre-diagnostic static evaluation, how many unknown primaries did you pick up? And there's a significant number of those.
I think there's some, but I would agree. It seems like it's, you know, in the, I would say it is been hard for me to do that given how many false positives we would find in order to find that number. There are a lot. And I, you know, and especially when that turns into, well, we need to do a lobectomy or a wedge resection beforehand, you know, and patients can have complications from those procedures. I mean, it is, I would say, not a benign procedure or not a benign thing to sort of get that information because you have to act on it. And the question is it going to change what we're now for these patients?
Thank you, Steve.
All right, thank you.
Thank you very much.